Lower back pain red flags. This is an excerpt from a full presentation on lower back pain generally, and here is a link to the full presentation. Now, the red flags. Normally, a larger percentage of people with lower back pain will have no red flag, and the treatment will be very, very mild, sometimes none, and there will be no long-term complications or horrible outcomes. But few people will not be that lucky. They can present with lower back pain, but the cause or causes might be something more serious. In fact, could be something that will require emergency intervention. The intervention might even go beyond orthopedic department, can even involve cardiothoracic unit. Sit back, let's go through red flags. What we can pick during the history and physical examination, including investigations, and we must act fast. As a matter of fact, we'll be looking for red flags when someone presents with lower back pain. And here, my number one diagnosis that will make me run quickly will be caudal equina syndrome. Here, I have full presentation on caudal equina syndrome. The caudal equina means hostile. Here, spinal cord passes through the vertebral column and it covers the lumbar and sacral nerve roots. The caudal equina is the bundle of nerves at the end of the spinal cord. At the lowermost part in the sacral region, that is where you're going to find the caudal equina. Caudal equina, once again, means hostile. Now, it is a surgical emergency, all at the perineum and external genitalia, including the anus. There will be saddle anesthesia, meaning the area in contact with a saddle while you are riding a horse. Then there will be sensation of pins and needles at the perineum, including numbness and loss of pain. The lower back pain in caudal equina syndrome will be very severe. There will be sciatica, paraplegia, fecal incontinence, urinary incontinence, erectile dysfunction in males, decrease or absent reflexes. The individual will be falling frequently, apprehension and depression. The sciatic nerve is L4, L5, S1 to S4. The caudal equina is L1 to L5 and also S1 to S5. The causes of caudal equina syndrome will include trauma, like road traffic accident, compression fracture, ballistic trauma, or iatrogenic, particularly from lumbar puncture. So on causes of caudal equina syndrome, it might be lumbar spinal stenosis, ankylosing spondylitis. I've left a link earlier. I'm going to leave again. Might be Paget disease, rheumatoid arthritis, osteoarthritis, TB of the spine or pulse disease, obesity, heavy lifting, or pregnancy. The history here, that is in caudal equina syndrome, will be that there is history of pulmonary tuberculosis that has now disseminated, leading to pulse disease, or history of trauma, pregnancy, or autoimmune conditions, and so on. Then there will be physical examination, and then magnetic resonance imaging will be the best diagnostic procedure. CT and ultrasound to check the bladder because there will be urinary incontinence. How do we treat caudal equina syndrome? The definitive treatment is emergency surgical intervention for decompression, and that could be laminectomy. But before the consult will get to the surgeon and it will come, you can give analgesics. If there is infection, you give antibiotics, and if there is an abscess, then there must be incision and drainage. When tumor is picked, the tumor must be taken out, excision of the same. In the case of inflammatory process that is identified, we give steroid. Still on treatment, we will later advise the individual to embark on lifestyle changes, particularly if the body mass index is pretty high. Then Kegel exercise. Early intervention will be pretty helpful in preventing long-term damage. The key here is early detection and immediate intervention. Another reflex will be ankylosing spondylitis. Here, there's a full presentation on ankylosing spondylitis. Please click on this very link to lead you to full info on ankylosing spondylitis. But I'll just briefly mention something about it here, that it is a chronic inflammatory disease of the axial skeleton, and you are going to pick bamboo spine. But ankylosing spondylitis is not limited to the spine as a problem. It is going to affect the eyes, leading to uveitis, fatigue, generally. The pain here will be severe at rest, but at the same time, it's going to destroy the aorta, acute aortitis. So ankylosing spondylitis is a very serious problem that must be dealt with immediately. Another red flag will be dissecting abdominal aortic aneurysm. Well, my thinking is that this should not even be under lower back pain, red flag. And someone will fight me, for that, right? Well, that's fine. But do you know why I've said that? We will pick problem in the chest region radiating to the back. And it's going to be sudden. The pain will be so sharp, tearing and stabbing. And of course, there will be dizziness, shortness of breath, and when we take the blood pressure, there will be hypotension. So it is good that it is under, red flags for lower back pain, but the presentation will be so classical that you can't miss it. This is more than lower back pain. Another red flag will be unexplained weight loss. Let me explain the unexplained weight loss. Here, you've not been dieting. You've not had surgery. You are not taking pill to reduce the weight. You just, find out maybe through regular weighing and everything, or your pants or shoes or wristwatch, that you are losing weight. But you have lower back pain. That may be pointing to something serious. It's probably because you are having cancer. So better see the physician and let them do everything right now. And this could also occur in people with tuberculosis that has disseminated and has affected the spine. So TB of the spine or pulse disease could also give us this feature. Now, red flags might be that the pain is very severe. Remember, I said the typical presentation would be dull, aching pain, right? That is aggravated with movement and alleviated when you rest or put yourself in supine position. But when the pain is very severe and it is localized, then something is serious here. If the pain is so severe or unrelenting to the point that it's affecting your activities of daily living, then we know it's no longer a joke. Another problem that will give us concern is if it is not responding to interventions, oh, then there's trouble. Or it is lasting more than 6 weeks, or the pain is waking you up at night, then we have to dig deeper to get the cause. When there is lower back pain with constitutional symptoms, then we know we are dealing with something serious, like fever, chills, and night sweats. Or there's lower back pain, but this individual is immunocompromised. Or this person is using intravenous drug users, or this person is on steroid for a very long time, or there is history of trauma with possible fracture. Another red flag would be that the pain is radiating to below the knees, or the pain increases with coughing. That is pointing to a herniated disc, or there are neurological deficits. If that is the case, we are likely dealing with cauda syndrome because it will be rapidly progressive. So rapidly progressive neurological deficit is pointing to cauda syndrome. And remember, that is an acute emergency. Another red flag will be the age at presentation. Anyone less than 18 will give us a big concern. The reason is the common age for benign cases will be 30 to 40, although benign cases can occur at any age. Now, someone less than 18 will be thinking of spondylolysis at L5 in early adolescence, which can progress to spondylolisthesis at L5-S1 slippage. But spondylolisthesis can occur at any age. So when we see somebody less than 18, we'll be thinking of spondylolisthesis. Another red flag under the age would be someone older than 50. Here we'll be thinking of something as serious as dissecting abdominal aortic aneurysm. Here, consult will be sent to cardiothoracic surgeon immediately. Imagine, from lower back pain presentation to cardiothoracic surgery. Spinal stenosis, secondary to degenerative disease, will also be the probability at age greater than 50. Malignancy could be the issue here also at more than 50. Vertebral compression fracture is another possibility here. Then spondylolisthesis at L4, L5 slippage in female adults due to degenerative disease might be the issue at greater than 50. Remember, I've said something about that earlier, but I won't mind because you need to get the facts right. So someone older than 50, why is that a red flag for us? It is a red flag if it's a woman, particularly postmenopausal women with decreased estrogen. And why that? That will lead to vertebral disc degradation. And that will lead to ligaments becoming loosened with spinal instability. There may be or not other associated problems, but that on its own can lead to vertebral slipping from the upper one over the lower one, like L4 slipping over the L5. And of course, we know what that will lead to, right? Back pain that will radiate to the legs.